Hello, everybody, and thank you so much for joining us today for another one of our Meet the Specialist sessions. Today, we have the very lovely Dr. Phil Lockie, who is a gastroenterologist and bariatric surgeon. He specialises in minimally invasive procedures. He has an absolutely amazing resume of his credentials and his experience. He is a really interesting guy, and he's got a great Scottish accent. So over to you, Dr. Lockie. Let's have a little bit of a meet and greet and see what you're all about. Hang on a sec. You'll have to unmute yourself. Unfortunately, you're...
Yeah, when you hit
sorry.
Yeah, that's okay. So sorry about that. Yeah, I have to...
What is it's happened again? I'm sorry. Can you
Yeah.
I don't know what's happened there. So I was actually trying not to mute you. I'm trying to mute Andrea. Andrea, can you please mute yourself? Thank you.
There we go. Everybody all good?
Yes. My apologies.
Yeah.
Please continue.
All right. Yeah, so I have to correct you and actually say it's a Northern Irish accent. I'm originally from Belfast, but that's all right.
Sorry.
And I would say I was a general surgeon, not really a gastroenterologist. I am GISA qualified for colonoscopy and gastroscopy, but technically I'm a general surgeon. I have interests in bariatric, upper GI surgery, and hernia surgery as well. It's one of my things. Sort of a quick resume. I did most of my training in Belfast. I then came to Royal North Shore for a fellowship in 2003. I then did another, that was an upper GI fellowship. I then did a laparoscopic fellowship in Canberra. And in between times, I went back to the UK to sit our intercollegiate exam, which is the exit exam in the UK for all of the surgeons in all of the 4 colleges. And I was the first person to win the gold medal from Belfast, which I very much put down to the excellent time I had in Royal North Shore particularly. I then spent a little bit of time as a consultant in Belfast before then returning to Queensland, where I have been ever since. I maintain a public position. I enjoy the teaching of registrars in the public, although it is the majority of my stress when it comes to dealing with hospital executives.
Yes.
And then I have my own private practice, as I say, upper GI, hernia, and bariatrics. My father was actually, was a barrister and a judge back in Belfast. So I have always had an interest in medical legal work. I've been exposed to that, obviously, for a long time through his work, reading some reports for him and giving him some medical feedback along the way. So I do enjoy the medical legal work. We were discussing prior to people joining that, I think it's important that we do contribute to the knowledge base. I am a bit of a stickler for, providing a report to the court as opposed to who is paying me, which doesn't always go down well with some of the solicitors who tend to feel that you should be weighing your report depending on who's paying you. Obviously, that's not what we're supposed to do, but there are some hard guns out there that can seem to be unduly influenced in that regard. And that's really a sort of a quick summary of me and what I'm about. I don't know if anybody wants to know anything else from that point of view.
I have a question from a person who's unable to attend today, but registered to attend, and they wanted to know in relation to workers' compensation, workplace accidents involving hernias and hernia repair. What is the sort of current wisdom on that, or what's the current trend?
Yeah, I get a lot of those through work cover, mainly from acting for or requests from employers. The current feeling is that hernias are generally a collagen disorder, reflect a collagen disorder. So you'll get some people who have lots of hernias, and dad has had lots of hernias. And that's probably due to them having some sort of collagen disorder that predisposes them to developing hernias. generally speaking, unless you can have one particular event where somebody lifted something very heavy and felt an immediate episode of pain or noticed an immediate lump, then generally I would say that your employment and a tendency to heavy lifting or manual work is not considered a causative factor for hernias.
Mm-hmm.
It obviously will make it more likely that that hernia is going to be symptomatic and that patient is going to require earlier intervention. But in terms of a causative factor, it's not generally, I think, accepted now that heavy lifting outside of the criteria where you've got a particular event, it can be considered a causative factor. There are other things that contribute. Obviously, history of smoking is a big thing, chronic coughing and that sort of stuff. But for employment, you can be involved in heavy manual lifting all your life and never have a hernia. So that's my tendency to say, unless it's been documented with an event, we can't say that it's a causative factor. We can say it's exacerbation of probably a pre-existing condition.
Great. Does anyone have a question that they would like to ask of Dr. Lockie? If you do, you can unmute yourself and pop in. Okay, good. I have another question, and that's what you and I were talking about before we switched on the recording, and that's about consent, and how clear and explicit should consent be, particularly for bariatric procedures, but in any event for laparoscopic procedures as well.
Yeah, well, generally, I think consent should, particularly for bariatrics, consent for me involves a process. So it's not a single event. So for patients in my practice having bariatrics, I will see them at least 2 or 3 times. And then ideally also consent should involve some sort of document that the patients can take away and read. My bariatric consent, I have a consent for each procedure, and it's about 4 pages long. Outside of that, for general surgical cases, I use printed documentation. There are a couple of sources. The college produce some, and then there's another organization that I use that produce written information that is updated on a regular basis. Just from a medical legal point of view, it is important that if you are supplying the patient with written documentation, that if you change your documentation, that you make a note of that. Ideally archive your old written information and date your new written information. I have been involved in situations where the patient or there's been an issue. The surgeon has said, well, this is the information I provided to the patient, and the patient then actually said, well, no, that wasn't what you provided me. And it turns out that the surgeon had at a subsequent time changed their information, and the patient was correct in that they were referring to an older document.
Wow.
So from a medical legal point of view, it's helpful to just, as I say, archive your old information, record when you changed it. The information that I use that I get commercially, it has an expiry date on it. It's usually annually. So that's just, so you can say, well, up until the 1st of June, I use this one, and from the 1st of July, I use this different consent form.
Wow.
It can be.
It's a minefield, isn't it?
Yeah.
And of course, people operating out of a number of different premises, a private hospital, a public hospital in their own rooms, they have to make sure that what their staff have at reception to hand out to clients and what's in their folder that they print off is all the same version of the documentation.
Yeah, the other way of doing that, obviously from a practice point of view, is to have a practice folder that you then update on a regular basis, and it's another source of archiving, so that you can then, if you update your practice folder on a certain date, you can then reference back to that and say, well, that was our our practice information up to this date, and this is the new folder that we
Mhm.
instituted at such and such a date. So there are different ways of doing it, but basically keep a note of when you change things.
Right. One last question. What is the most common type of matters that you're seeing coming to you at the moment?
As I said, in the world of hernia surgery, I mainly see patients on behalf of employers who are claiming for hernias. A lot of the big employers in Queensland do self-fund their work cover rather than going through Queensland Health Work or Queensland Work Cover. So they have their own insurance schemes. So I see a lot of people who are claiming a hernia as a result of an injury at work. That's the commonest general surgical thing that we see. Obviously, we get some permanent impairment requests, often with inguinal surgery. You can get chronic pain, chronic groin pain, things that unfortunately are not particularly well assessed or managed. The American Society actually has a book which I have purely on groin pain, on assessments and treatments of groin pain. One thing that's very useful for groin pain is dermatome mapping, which is relatively simple to do. You basically map out on the patient where they're feeling numbness or hypersensitivity, and there are certain there are certain patterns that fit with certain nerves in the groin, the ilioinguinal, iliohypogastric, genital branch of genital femoral nerve. The other thing that could be useful is you can repeat that, and obviously if you get inconsistencies in what you're seeing, then that would tend to suggest that there may be other things at play. So we see a number of those, and then within the bariatric world, it's claims for medical negligence, and unfortunately, as a bariatric surgeon, our indemnity premiums are steadily rising due to increased claims histories, according to my insurer anyway.
Goodness me, it's a big thing. Well, look, thank you so much, Dr. Lockie, for your time today. And now our clients can hop on and watch your Meet the Specialist and see what you're all about. And you can book with Dr. Lockie by calling my team, and they will arrange an appointment for you for an assessment with this amazing guy. Thank you so much, and have a great rest of the day, everybody.
Thank
Bye.
you. Bye.